Hello, everyone. Thank you so much for joining in for the Designathon Open Knowledge webinar. Really appreciate you making the time to join us today as we're looking to bring in innovators and contributors and other solution-oriented folks to come together to focus on the challenge of ending the HIV epidemic. Really appreciate the time again. My name is Alessandro Ciari, and I'll be just waiting just a moment just to let some folks come in who might be coming in a little bit late. But during this time, I'll just give a little bit of an introduction of myself and Firefly Innovations, and also about the Designathon overall. And today, we're really happy to announce that we launched our website and our application process to join the Designathon. And so when you have a chance, you can definitely chime in there and check out our new website. And it is at firefly-innovations.com/designathon. And I actually just sending that out to everybody in the chat room right now. And so you can just copy and paste that directly into your URL. And from there, you can see more details about the event, really the challenge that we're focusing on, the purpose of this event, more about our application process and accessing the actual applications themselves. So when you have a chance and check that out, that would be really wonderful. Thank you so much for doing that. Now, just to start out here, I'm just going to be sharing my screen. Now, again, my name is Alessandro Ciari, coming from Firefly Innovations, and the Designathon focusing on this topic is our first time, and we're really excited to focus on this specific challenge that is such an urgent public health challenge. And I come from the CUNY School of Public Health and Health Policy, which Firefly Innovations is based in, and we are sponsored by the NYU CUNY Prevention Research Center, which is a partnership between NYU and CUNY that focuses on research to address health disparities in New York City. And we're also based within the Center for Systems and Community Design, one of the research institutes and think tanks of the CUNY School of Public Health. And now with the Designathon, this is a kickoff event, and this panel today is featuring expert panelists covering the gaps and opportunities in the field of HIV prevention and PrEP uptake. The Designathon is a one-day, highly interactive event of bringing together innovators and contributors focused on generating solutions to address this challenge on September 18th, 2021. Now, today is just sort of like an informational session, a way for all of us to get together and start to build a community around this. The actual event is on September 18th. And you can check out more about the website, again, on firefly-innovations.com/designathon, and apply to be in the event as an innovator or contributor. There are also other ways to get involved as a volunteer facilitator. You can definitely get in touch with me about that. And in the Designathon, we aim to foster a solutions-focused community to generate and refine novel ideas that can transform this urgent public health challenge, particularly for men of color who are disproportionately affected. Through the webinar today, we aim to set the stage for this one-of-a-kind event by sharing the most recent findings in the field and connect with all of our attendees here today to build a community of solvers who will join this Designathon in September with their own ideas or contribute to accepted ideas. We aim to connect with people who come from all types of backgrounds and sectors, whether it's business, tech, health, communications, marketing, art, and make many more of all these types of roles, which is all so necessary to designing and developing a truly impactful product and organization, or whatever type of solution yours may be. Again, you can learn more about the Designathon on our website. And I just want to give thanks to all of our partners involved in this program. And it is the big partner of ours is the Center for AIDS Research, a collaboration between Einstein, College of Medicine, Rockefeller, CUNY, and CUNY. And all of them together have, some folks from this partnership and this institution are joining us today as panelists. I thank them very much. And of course, MOBI, Mobilizing Our Brothers Initiative, that has been a major part in helping us really promote this event and being part of really setting the stage and creating the right type of communications plan going forward. And so they've been an amazing partner of ours as throughout this process. And just to make the Designathon process possible, this has really been a cross-institutional effort with partners spanning across various backgrounds. And that is really the essence of what we would like to get across with the Designathon coming up. So work is having folks from different types of backgrounds and sectors working together to drive forward solutions. Now today I want to, without any further ado, I want to introduce our moderator as Dr. Stella Safo. Dr. Stella Safo is an award-winning HIV primary care physician and assistant professor of medicine at the Icahn School of Medicine at Mount Sinai. She's the program manager for systems design at the Arnhold the Institute for Global Health in the Mount Sinai Health System, which develops and evaluates global health solutions which can be replicated at scale. She leads the design and development of effective population healthcare models. Passionate about medical education and racial and gender equity, Stella serves as a lecturer and mentor for all levels of medical trainees across US and in Ghana. In addition to publishing in several peer-reviewed journals, she has written for popular medical media such as Stat News and Kevin MD on gender equity and physician wellness. Entrepreneurially, this year, Stella created Just Equity for Health, a healthcare improvement company that uses advocacy, education, and care model design to ensure equitable care delivery across all sectors of medicine. Now currently based in Harlem, New York City, Dr. Stella Safo, thank you for joining us.
Thanks for having me. And it's really a pleasure to see all of you guys joining us today because we're very excited about what we're all going to come up with as part of this Designathon. And so I have the pleasure of introducing some of our speakers for tonight and eventually getting to our panel speakers for tonight. And so just some kind of remarks to get us kind of really focused on what it is that we are trying to do together. So we know that to end the HIV epidemic in the US, particularly among same gender loving men, that it's really critical that we increase the uptake of consistent HIV testing and PrEP use, especially in men of color who are disproportionately currently affected by HIV. PrEP has proven to be so effective that it can lower chances of getting HIV from sex by more than 90%, and its use has increased drastically since 2014. And yet there's still barriers like racism, stigma, homophobia that remain that make it hard for certain groups, such as Black and Hispanic men, to uptake PrEP, and this, of course, will lead to worse health outcomes. So to end the HIV epidemic and to increase PrEP use, new communication strategies are going to be needed so that we can really get towards that PrEP uptake. And so this particular webinar is really aimed at achieving 3 goals. The first is to establish current evidence-based set of kind of best practices around how we can have same gender loving men really engage within PrEP uptake within healthcare settings with a particular focus on men of color. Secondly, we want to develop a network of multidisciplinary stakeholders, all of you, which include community entrepreneurs, researchers, communications and marketing experts that are really committed to addressing the challenges of overcoming stigma to facilitate PrEP uptake. And we're very, very careful in kind of noting that we believe that this multidisciplinary group is needed because we know that the solutions will not be found within kind of traditional lines of healthcare alone. And our third aim is that we'd like to use the knowledge and network that we are creating here among you community of experts and advocates to launch a Designathon, which is aimed to source, to generate, and to refine innovative solutions to support healthcare providers who are working hard to make sure that these at-risk groups have PrEP uptake. And so we have some really great panel guests today, and we're going to be discussing some of these topics that relate to these 3 aims, including stigma, medical system distrust, appropriate messaging and media campaigns around HIV-related services, and PrEP eligibility and disparities in PrEP uptake. Our guests include Dr. Viraj Patel, Christian Grov, and David W. Matthews. And before I bring the discussion over to them, I do want to introduce Pedro Carneiro, who will speak with us about some of the research that's being done among the partners of the Designathon. And that's focused on the issues between patients and providers in communicating around PrEP uptake. So to introduce Pedro, Pedro is a doctoral student in community health and health policy at the CUNY School of Public Health. He serves as a clinical data scientist at the National Association of Community Health Centers, and his work focuses on understanding the determinants of uptake and adherence to HIV biomedical prevention. In 2016, Pedro was awarded the Joe Lange and Jacqueline Van Tongeren Prize for Young Investigators by the International AIDS Society for his work on implementation research and PrEP. So I'm going to turn it over to Pedro.
Thank you so much. Such a nice introduction. Hi, everybody. It's great to be with you. I'm going to share my screen and probably get the wrong type of presentation, and then you tell me so I can switch.
Works just fine.
Okay, but are you seeing the which type? Are you seeing the right one or the wrong one?
We're seeing presentation mode.
Okay. Thank you. I don't know how to ask that. Sorry. Okay. So today I'm going to talk to you about some work that we did, and some of the collaborators are here. So just want to thank them in advance. And it's titled Providers as Gatekeepers of PrEP Access. And just to get us started, I just wanted to give a minor background in the HIV epidemic and the PrEP uptake situation in the United States, some of it which already has been said previously by our moderator. So a little repeat, if you will. So between 2014 and 2018, the United States averages about 37,000 new infections of HIV. You can see this graph here that I posted, although it seems like it's going down, you can really see that the numbers are really not fluctuating that much. 60% of those new infections are among Black and Latinx individuals. And the CDC has estimated that Black MSM, men who have sex with men, have a 1 in 2 lifetime risk of acquiring HIV or seroconverting. And for Latinx, that risk is 1 in 4. So it's a really big deal for these communities. When we think about, when we think about PrEP uptake in the United States, the CDC has identified 1.2 million PrEP candidates in the United States. The first epidemiological report from the CDC in 2016 reported that about 80,000 people had initiated PrEP by the end of 2016. So that's about 6%. And the most current estimate, which is done by this organization called AIDS Watch, has that number at it's an estimate, about 200,000 users of PrEP in the United States. So although we can see some success in smaller communities and regional, maybe in cities and in some spaces, this is a really big issue that hasn't really been resolved yet in the United States. And challenges with PrEP uptake are various, right? So there's sort of 3 major areas that we think about when we think about challenges in uptake. So first is initiation, right? Identifying good candidates, talking to them, getting them the medication in their hands. There's also like issues with adherence once you start taking the medication. And then there's also issues with persistence and like what drives you to continue taking the medication. In this talk, we're going to focus around the issues of initiation, and we'll talk a little bit more what I mean about that. But when we think about initiation, we're thinking about psychosocial factors, like it has been said already. So the initiative to ask for it, the stigma that is associated with that, perhaps shame. There's also racism, right? We always homophobia, and then there's also like very kind of objective primary care factors, right? Lack of time, too many demands in primary care, perhaps the provider discomfort talking about sexual health, maybe unawareness of PrEP, lack of competency of dealing with perhaps LGBT patients. And there's also this thing called the purview paradox, where somebody will say, well, you know, you really should be going to an infectious disease doctor to get PrEP, when we know it's really like a primary care thing. So how is PrEP prescribed in the United States, right? Currently, the only way to get PrEP in the United States is through a medical provider. So you have to go to a doctor, any type of medical provider, as a matter of fact, and you have to request that, and they have to write a prescription for you. New guidelines that are coming out with PrEP are going to add more options, right? There's going to be PrEP 211, long-acting injectables. In the future, there's going to be monthly PrEP, implants, douches. So all of those things create the situation where the provider has to do all this education and explaining and introducing new concepts and discussing behavior with patients, which is great, but oftentimes there's not enough time for that. So thinking about that, thinking about the providers as gatekeepers and sort of the people that provide a medication to the patients, we looked at the Together 5000, which is this internet-based national cohort of cisgender men and transgender people who have sex with men. And that's a project led by Christian Grov. And all participants in that study, they meet eligible criteria for PrEP during their recruitment phase, the baseline. And that means they recently were diagnosed with the STI, or recently used PrEP, or had condomless sex with a man, or shared needles or used crystal meth. In our analysis, there were about 6,200 individuals. In that survey, there was a question about communication with a medical provider about PrEP. And that question asked the following: have you ever spoken to a medical provider about starting PrEP? And keep in mind that all of those participants were eligible for PrEP. And here are the options. No, I have not spoken to a provider about starting PrEP. Yes, and we both decided it was a good option for me and I should start using PrEP. Yes, and we both decided it might be a good option for me, but I should wait. Yes, we both decided it was not a good option for me. Yes, and the provider was not comfortable prescribing PrEP. And yes, and the provider thought it was good, but I chose not to do it. So we looked at that question and how the participants answered that question. And we looked at who spoke to a provider about PrEP, and then who answered each of the potential answers. So what did we find out? We found out that only 31% of those 6,200 patients had spoken to a provider about PrEP. There were some demographics differences. People that spoke to a provider were slightly older, slightly wider, slightly richer. It wasn't that meaningful, and I'll show you the numbers, but there were major geographic variations. So people in the South were 28% less likely to have spoken to a provider compared to a person in the Northeast. Similar in the Midwest, a person in the Midwest was 15% less likely compared to a person in the Northeast. However, and one of the things that was the most important was having a primary care provider increased our measure of association by 1.5-fold. So obviously that was what facilitated having that conversation, and we can all understand that. So how were the answers? So out of this 31% of people that spoke to a provider, and you're gonna remember, I'm gonna say one more time, all of them were eligible for PrEP and likely could go on PrEP. Only 45% of those ultimately decided, along with their provider, that PrEP was a good idea for them and they should start. I want to call your attention to the 17% here in the bottom that said that spoke to a provider. The provider thought was a good option for them, but then they chose not to do it. There's also this 15% that decided that PrEP was a good option for them, but then the provider was not comfortable prescribing PrEP for them. And then, yeah, you can see the rest of the distribution. So what were some of the main highlights of all of this that we found? First, we found that provider discomfort was associated with geographic location and more common among white patients. So when a white person was more commonly report that the provider said that they were uncomfortable prescribing PrEP. We also found that the decision to wait to start when the provider and the patient decided PrEP is good for them, but they ultimately say, but let's wait. That was more common in younger people under 24 years old. And deciding not to start PrEP when the provider thinks it's a good idea for you was something that was more common in Black and Latino participants. And for those that like to see numbers, here are some of those highlights. The first one over here shows you that younger participants had more likely to choose to wait. The second row here with highlights shows you when the provider was not comfortable. And all the way here in the bottom, you can see the prevalence ratios for the different regions, how they were large. And then in the very last row, you can see the prevalence ratios for Black and Latinx. And this is the option that you both think it's a good idea. The provider thinks a good idea and you decide not to do it. So what we learned from this project is that simply having a clinical indication for PrEP does not seem to be enough to ultimately initiate PrEP, right? We only saw 30% of people had spoken to a provider, and out of this 30%, only 45% ultimately initiated PrEP. When you think about the amount of people that we're trying to bring in under this umbrella, we see the task ahead of us. So thinking about primary care visits, they are indeed too short. It is something that we hear in the literature. There are competing issues. There is little time for patient education, which lead us to believe that perhaps more support is needed outside of the medical provider's office. So like more things like PrEP navigation, technology-driven solutions, things that are called clinical decision support tools, electronic health record things, apps. There's a thing called FHIR language, which is a type of technology that can facilitate sharing of health information. Multidisciplinary care teams are needed, right, to ultimately help with the education and the navigation and the follow-up. And more interoperable solutions. So here I put it again, clinical decision support tools, sharing of data across medical practice and medical apps, modernization. We generally call that interoperability as sort of like an umbrella term. And that's my presentation. I just wanted to thank everybody. And I think we're taking questions towards the end, but I have my email here, and I welcome anybody to ask me anything.
Thank you, Pedro. That was excellent. And it's a really perfect way for us to start. Pedro will be with us for the evening. And so we see a question in the chat. As a reminder, please continue to include questions in the chat. After we have a bit of a discussion with our panel, which will include Pedro, we'll be turning it over to questions from the audience. And so I want to go ahead and introduce our panel. And we have some really great folks on our panel. I'll just ask, if you don't mind, we'll do the awkward Zoom wave when I mention your name. But I'm going to go ahead and start with Dr. Viraj Patel, who's a physician at Montefiore Medical Center, and he's an assistant professor of medicine at the Albert Einstein School of Medicine. Viraj's research centers around community-engaged approaches to HIV prevention, particularly with sexually minoritized men and gender minoritized communities in the US, India, and Rwanda. His current research focuses on developing and testing technology-based behavioral interventions, such as social media, mobile apps, to reach and engage underserved communities, as well as leveraging online social networks to improve health outcomes. He's also focused on implementation and scale up of PrEP for preventing HIV in clinical and community settings. So thank you for being here, Dr. Viraj. We also have Christian Grov, who is a chair of the Department of Community Health and Social Sciences at the CUNY School of Public Health. And his research centers on the sexual health of sexual minoritized individuals, particularly gay and bisexual men. His work has explored substance use, sexual compulsivity, and venues where individuals meet sex partners. Christian has authored and co-authored more than 175 publications, including the book In the Company of Men, Inside the Lives of Male Prostitutes. And he's co-authored the Handbook of Male Sex Work, Culture, and Society. Thank you for being here, Christian. And finally, David Matthews is a research associate at the CUNY School of Medicine with 20 years of management experience working within social science and nonprofit organizations. David has worked in the areas of community public health and social justice work, and he has a focus on HIV prevention and care. Also focuses on LGBTQ challenges and barriers, as well as adolescent, young adults, and adult population barriers. Additional populations that David's work is focused on are the homeless population, active drug users, and those with mental health and those needing harm reduction interventions. So welcome to David, Christian, and Viraj, and we are all going to be joined by Pedro as well. And I'm going to start off by some directed questions to our panel members. Again, please continue to include any questions that come up as we're talking in the chat box so we can make sure that we get to any issues or any questions that this conversation may bring up. So I'll start with you, Viraj. So, you've been working in the field of HIV prevention and treatment for some time. And as a healthcare provider, I think it'd be helpful for this group to really hear about some of the biggest challenges in implementation and scale up of PrEP in the community setting, as well as in the clinical setting, because although we are positing that we need to go outside of these settings, I think just understanding what it's like within those settings would be helpful. So if you can kind of give us a little bit of a sense, that'd be really great.
Sure. Thank you, Dr. Safo. So healthcare in the US is a mess. Let's just put it out there. It's a mess, and we don't really have a system. Therefore, we create all these, or we try to create Band-Aid solutions to sort of meet our needs, but these Band-Aid solutions are expensive. They don't really fit with the most of our lives and priorities for obtaining services and getting the help we often need in a timely way or at the time we need it. And so stemming from that, there's a lot of challenges. And a lot of these challenges have been seen previously or continue to be seen with things such as contraception for cisgendered women who are seeking those services. For young, healthy individuals, our healthcare system is really designed to support a chronic disease model or a chronic care model. And hasn't historically been very friendly towards many communities or many folks who are otherwise healthy and have different priorities and needs in their lives. So if we can imagine, a simple thing as making a face-to-face healthcare appointment or appointment for a routine physical or a form that you need completed when you're in school or whatever it may be, involves first navigating the issues of finding someone that you can see, if you have insurance, first of all, if they'll take your insurance, and if there's availability, and if the availability matches your schedule. Once you do, and that can take a lot of effort and energy and time and skills to do that. Once you do that, commuting to the clinic, waiting, getting checked in, registered, getting prepped, and then finally seeing the physician, for 5 minutes, for 10 minutes, for, perhaps if you're fortunate, 20 to 30 minutes, and then going to a lab and then commuting back to wherever you need to go. So that, often can take 2 to 4 hours. So if we think about that for someone who's in school, someone who's working, someone who's providing care as a caregiver, or lives far from a place, there's lots of challenges to accessing care. That being said, once you add sexual health to the mix, it becomes even more complicated. So, to be frank, a lot of providers are not great at providing sexual health care. Our training historically has not been very sex positive. And especially has excluded specifics around sexual and gender minority health and health issues for different and diverse populations. And so when you add all of that, there's oftentimes there's not a whole lot of individuals or providers who are equipped to meet the needs of diverse populations. So our system is broken in that sense, and then the solutions, and therefore we need solutions that can address these broken systems that can actually meet the needs of clients or patients today. And that's within the healthcare setting. And when we think about outside of our healthcare walls, thinking about, well, who is able to access care first of all, and then once you can access care, do our clinics and current system meet the needs of the population? So again, as I mentioned before, how does the system for providing PrEP or providing preventive care, and it's not even restricted to PrEP in that sense, meet your needs? And can you find a provider who can even communicate with you or make you feel comfortable, or a clinic that can make you feel comfortable and safe to, whether you're a same gender loving man, if you're having multiple partners, if you're engaged in sex work, whatever it may be, are you able to disclose those things safely and feel supported and not judged and get the care that you need? So I think we have a lot of challenges ahead of us, but I feel optimistic that perhaps with a very diverse group of individuals that we can come up with innovative solutions to try and do things better.
Really well said. And I think one of the takeaways from Pedro's work and the work that he and Christian and others are doing together is that you need an activated population that engages with this healthcare system. In some ways, you need patients to come and say, I would like PrEP and I'm going to need you to give it to me, rather than maybe waiting for a healthcare system that, as you've just described, has a lot of barriers and is often very reactive. And I think, Christian, going to you, one of the questions I think that comes up as we think about PrEP is, how do we engage with populations that are at higher risk, but are not populations that maybe some providers may feel comfortable interacting with? And so specifically speaking to populations of sex workers or those who may be less traditional in kind of the ways in which they're engaging in sexual health. What are some of the lessons in your work with them around just, wellness in general that I think this group can be thinking about as we think about advocating for increased PrEP use?
Sure, and let me say a few things. So there was a comment in the chat asking the question, who brought it up first? We did ask the question, did a conversation happen? But to your point, are we going to the patients, or are we expecting the patients to come to us? We don't have the data. We can collect it in a future round to figure out who initiated the conversation. But that's an important number one. To echo what Viraj said, and Pedro didn't have this in his slide, at enrollment, 27% of participants did not have health insurance, which is, a barrier to getting access to healthcare. And among those that did have health insurance, and forgive me if I'm duplicating what was in Pedro's slide, something like 54% of participants said they didn't have a primary care provider, sort of as two barriers. And I guess that just sort of echoes the mess that our healthcare system is, and maybe the lessons that we can learn from other westernized nations that have universal healthcare, where you don't have to go through the steps of getting insurance and going through the steps of getting to a provider. You have both of them automatically. And this is maybe a little off topic. I think that there are a lot of parallels to COVID that are lessons learned from HIV. And we're seeing this now with vaccine distribution, where, certainly there's vaccine hesitancy. So you're going to have people that just don't want to go on PrEP or don't think that PrEP is right for them. That's not the same thing as vaccine hesitancy, but you do get people who say, I don't want to put this chemical in my body, be it PrEP or vaccine. But now we have this situation where it's these harder to reach populations. I was listening to NPR yesterday, and it was a great segment about the number of nursing home care workers who are still unvaccinated, and why is it so high? And what the story attributed it to was, we're working, so many people have fled nursing home care because of all that happened, that there's fewer people in nursing homes providing care, so they're all working double shifts, and they don't have the time, to echo, Viraj's sentiment, to go out and even get a vaccine. So what is happening with COVID that might be a good parallel is the outreach. So the last mass vaccination site has closed, and now we're at a point where in New York, somebody will come to your home and deliver a vaccine to you. And maybe that is the type of healthcare that we need to start thinking about to get it into the hands of the people that need it most, is not expect a mass PrEP, vaccination site, but really doing a better job of going to people where they're at. I have other thoughts, but I want others to speak too. So.
Yeah, and if you don't mind, if you can speak to kind of some of the high-risk groups that we have historically tried to push PrEP towards, I think that's a unique perspective that you offer that I think would be helpful for us to hear about.
Yeah, I'll sort of harp on the insurance situation too, is that we have baked racial injustice so much into the United States that, difficulty getting access to, starting from not living in a great neighborhood that then has underfunded schools, that you then go get into college, that you then don't get necessarily a good job, or you're underemployed, and then you don't have access to health insurance, and all of this creates a cavalcade of a system that makes it difficult for someone to have the resources that they need to get access to PrEP. And please repeat your question, because I want to make sure I'm addressing it. You were saying.
Yeah, specifically talking about PrEP use that has historically been pushed among higher risk populations like the transgender population and sex workers, and thinking about the lessons there that have been successful and have worked, and how we can think about, as we think about larger populations, what are some of those that this group can be thinking about and really applying in those more innovative ways?
I will say, so I don't know if there are other I'm not a psychologist, but if there are other psychologists, I'd love to hear from them too. Because one thing that we've done wrong with PrEP messaging is we've said it's for risky people. And so, insurance stuff aside, targeting people and using that language and target populations and risky groups, we did a really poor job with messaging how people could benefit from PrEP's protection, rather than saying risky people, or I'm trying to think of the language, because I've completely reverted to people who would benefit from PrEP's protection as opposed to risky people. So that's another thing where we've certainly gone wrong with the delivery of messaging for PrEP for the populations that would benefit from PrEP's protection most.
That's excellent. And so, David, I saw you really react to that. And I think as someone who sits at that intersection of thinking about not-for-profit organizations, community organizations, what are some of the kind of insights and lessons from there? And also as someone who works with a wide span of, populations, young people, people with substance use disorder, people with mental illness, what are some of the lessons that we should be thinking about, exactly to Christian's point of not targeting, but really thinking about the wider, populations that could really benefit from PrEP uptake?
Exactly, Dr. Safo. Thank you for that. I'm going a little bit crazy over here, because one of the things that we definitely learned, so I'm the one who developed and implemented those Band-Aid kind of solutions and resources that Viraj kind of speaks to. We are funded by the government, right, to fill in the gaps and the needs that the medical system isn't able to provide because of the way it's designed. One of the things that you kind of learn in providing these kind of really important, critically important resources to communities of need is that those individuals who don't fall under those same descriptions are the ones who are really struggling the same. Honestly, if the CDC says that 1 out of every 2 Black MSM will be touch, be at risk or seroconvert in their life, then that means that professor who makes 100 and who knows how much $1,000 a year, who identifies as a Black MSM, is at the same kind of risk, no matter his level of intelligence, no matter how much money he makes, he's at the same kind of risk. It's that kind of guy that it is the most difficult to reach. And then once we do actually engage him, it's really difficult to keep him sustained in care. Why? Because of the classist aspects that we kind of impart on this particular kind of process. Never mind the fact that he can't go to his own primary care provider who he pays a fortune for, because that provider doesn't deal with this kind of stuff. He's got to go to an ID clinic, right, Viraj, where this whole purview, the purview paradox, right, that Pedro talks about, right? He's got to go someplace where he's not used to and or comfortable of going to get the kind of care that he really needs. One of the primary reasons why it's really, really difficult to keep him engaged in care, who actually just wants to be able to have his medications mailed to him and engage in care that way. So what have we learned, right? We learned that the nonprofit or the non-medical programs and initiatives and interventions are completely critical to this process. Once they started to introduce PrEP navigators and PrEP specialists to be a part of this particular process, who can escort his participant, right, to the medical doctor, who can help translate the medical mumbo jumbo. For the 5 to 10 minutes that the medical provider is able to engage a particular patient, my specialist, my PrEP navigator is able to engage the participant for another 20 minutes, 30 minutes, however long is needed, can make the phone calls, can send the emails, can facilitate the health insurance or the specialized programs that the participant needs in order to be able to fill his prescriptions. He's the guy or she's the person who actually sits with the patient or their HIV medication, right, their ART. Does it visually helps?
David, we're losing you a little bit. You may be in a place where your
internet
reception is coming in and out, but we can hear most of what you're saying. We just lost you for a moment, but you said how, we lost you at the how.
Right, how the participant can initiate their ART, initiate their PrEP regimen, and support that person with staying, if you will, adherent to the particular process. So we've seen a lot. What we have learned is that where the medical industry is unable to follow through and may contribute to gaps in needs, it's the non-medical team, if it's well put together, if it's well funded, if it's well resourced, can actually fill those gaps in needs. The problem is that because we are government funded, there's inconsistencies there, right?
Excellent.
We lose funding, we lose programs, and therefore the program loses patients. And that's a big issue.
Absolutely. And I think, going on this conversation, so we may not all be clinicians and public health practitioners, but we all are, to a certain extent, advocates, and certainly we're all patients, right? And so for the whole panel, starting with Pedro, can you speak to some of the innovations and or, current innovations or future innovations that patients should be thinking about, or we should be thinking about for the patient population as it relates to PrEP uptake, either things that you have seen or things that you wish could be implemented that would really help us to start to see these rates go up? And I'll turn it over to you, Pedro.
Thank you. So I agree with some of what Christian was talking about. I think that what we have right now in terms of sort of like the system in the United States, it's illness driven, it's disease driven. You go to the doctor because you have a problem or you're sick, so I think we need to reinvent sort of what is preventive care, what does it mean to go to the doctor to stay healthy. And I think some of it was discussed already. So like having services at home, like doing things in a convenient way for you, right? And I see a lot of, I think a lot of like digital applications, things that are more embedded in our daily lives. You know, I think we need apps, basically, or things that doesn't demand too many like logins and, you know, weird interfaces, but things that are more, you know, if you think about it, we already share our information willingly to many players, right? Whether it's your health insurance or whether it's Facebook. So we have to find a way for us to kind of share securely and in a way that like we feel comfortable with, but in the same easy way that we share with everybody else. Because I feel like with the healthcare system, for some reason, is more difficult. And, you know, I that's what I see as sort of like the next step. It's for PrEP uptake, at least, it's like developing this model where you want to be engaged. It's easy for you to be engaged. It is not a burden. It is not on you necessarily to have to remember everything. Things are gonna sort of conveniently occur around your routine and your needs, and you'll be able to manage that. I don't know if it's very abstract to me, but I have it in my mind.
I think it's a reinforcement of the themes. I'd open it up to others for other suggestions.
The only thing I would like to add to that, I agree with Pedro with a lot of the stuff that he's saying. The advancement of the usage of technology forced upon us by the COVID pandemic is almost requiring us to kind of take this particular part up. I would just like to remind everyone, though, that we've got individuals who are aging, who are still wonderfully having sex, right? Who are not as tech savvy or even have the capacity to utilize those resources, individuals who may be disabled, et cetera. Not that they can't get access to tech that can eventually support them in what their needs are. But I just don't think that the advancement of tech can be one of the kind of automatic and understandable ways to go, because there will be individuals who will resist that. And the other thing about it, Pedro and I'm curious what you think about this, and you too, Christian, is that I'm the co-investigator on the CHARGE project along with Dr. Fry and with Mark Page. And one of the conclusions that has definitely popped up for me is that it is the system that has the fault. Viraj spoke to that really, really well. Why are we, I hope we can support our customer base with making kind of some necessary adjustments so that, you know, they can get access to the things that they need. But I hope that they don't need to be forced to be the ones who are responsible to take up the changes that are necessary for them to get access to decent care, when it's the system that is of issue, and we should be putting the onus on the system to change. The patient should just be allowed to be the patient who pays in some way, shape, and form to receive services. The changes need to be with the system.
Christian, did you want to respond to that? I saw you shaking your head and loving it.
No, I just I saw Dr. Fry's giving the applause, so I made me giggle a little bit. This is one of those things. I certainly am not, but I wonder what the other group members think. Like when we're talking about a system change, you know, that is lobbying our, you know, congressional representatives, putting people in office. You know, voting for people in office who are going to create a better Affordable Care Act, you know, for instance. So rebuild the healthcare system. I don't have this. That's sort of where I sit on it. Like, there are facets of our. I don't think we will ever dismantle private insurance because the industry is simply too large. I know my sister-in-law works for Aetna. Like, you know, she will. dismantling private insurance altogether would be the same reason we can't get rid of the oil industry. It supports too many jobs and too many lifestyles. So, sorry, I'm off topic on that one, but I will say, if we are going to sort of think bigger, get out the vote to put people in office that are in favor of creating a system that will favor the people better.
But I would say, like, there are sensible steps prior to the revolution that, like, that we could technically take. Like, for example, right? What if your information carried over to wherever you go, so that not every time that you go to a provider, you have to fill out like giant amounts of intake and blah, 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 and paperwork and have that horrible experience, right? What if you go to the pharmacy and just get the medication that the provider prescribed for you, and you didn't have to deal with some crazy like prior authorization, or you have to order from a specialty pharmacy that will deliver by helicopter sometime in your house, right? Like, there are ways, or even creating better models. Like, what if the nurse could prescribe PrEP? What if you could ask for your pharmacist for PrEP? What if, like those clinics, rapid screening, Dean Street clinics were prevalent, and you could just, walk in through one door and get your entire screening and your PrEP without talking to anybody. And, you just did that on your lunch break. I mean, there's like, I think there's sensible steps that our archaic system doesn't allow us to function. If you think about the HIPAA law, right? It requires you to fax things. Like, what is a fax? No one knows. We don't even have that anymore. It's sent it as an email, but like, it needs to be a fax. What is,
Pedro, I think you're right. And I think one of the things, and this was already invoked earlier, talking about the lessons of COVID, one of the things that COVID has taught us as a community is how much innovation comes from, having every scientist, public health practitioner focusing on the same problem, and how, a true focus and desperation can lead to pretty incredible innovations, right? Vaccines that are being delivered to people's homes, at-home testing kits, things that just a vaccine delivered within 9 months, things that were thought of as impossible that we were able to generate. Viraj, I want to turn it over to you. And as I do, one of the things that has come up, and I think your research really speaks to, is the role of technology in all of this. And Alessandra will spend some time taking us through the Designathon and the technologies that will be used there. But technology to deliver better healthcare to populations is something that we always talk about as a solution. And I think David did a good job of saying, there will be some people who will be left out. Can you, in addition to kind of adding the comment that you had, speak to a little bit of your work using technologies to really engage populations in PrEP uptake and HIV prevention, and maybe talk a little bit about some of the downsides that we have to keep in mind as we offer this as, the kind of magic solution to a lot of what, we are seeing as problems.
Sure. And so, I think this actually builds on what many people have been saying, or the theme that have risen. And one of the things that we have seen happen that's actually been great from a policy perspective is paying for telemedicine and telehealth care during the pandemic. This was not a realistic option for most insurances, including Medicaid, and forget the payer aspect, but healthcare institutions were not set up or equipped to actually implement telemedicine and provide services via remote access for most people. And because of the pandemic, it actually forced change, and it accelerated change. And, large healthcare institutions were able to implement telemedicine solutions overnight almost, or, within a week. And insurance and government and Medicare and Medicaid and payers were all on board with paying for these services, like, in almost an overnight change in policy. And that, I think, has really transformed how healthcare, and has helped people reimagine how healthcare could be delivered and how we could integrate technology. And one thing that's telemedicine can mean a lot of different things. For example, it does not necessarily mean video to video visits. It can mean telephone visits, which were never covered or paid for before the most part. So, for example, me now being able to book a patient on my schedule for 10 minutes or 15 minutes and have a telephone call with them where I can actually give them my attention and review their chart in detail and provide information goes a long way by telephone versus having this elderly person, you know, sort of bring up the troops, get accessoride because they're wheelchair bound, even though they're completely mentally with it and are able to have a conversation, but get in a vehicle that can transport them to the clinic and just all the hassle where you just really needed to have a counseling session and discuss their lab results and talk with them about potential changes to their medication regimen or asking them follow-up questions and as such. And so these sorts of policy changes have had huge impacts in making the lives of both the health system and healthcare system decrease burden to some degree, as well as improve the efficiency and convenience for a lot of our patients. That being said, there still remains a large digital divide, and there's also issues of digital literacy. So not only healthcare literacy, but now we need to add digital literacy on there. So when you compound those things, there's certain groups or marginalized populations, or that society has marginalized, that will further be excluded from these technologies. And so that being said, technology is here to stay. There's a rapid uptake of mobile phones around the globe, including among the least resourced countries. However, it's not a panacea and it's not going to be the magic bullet. There's still, there's still a human behavioral element to it. And it's not a one size fits all solution. And so our, whatever changes we propose need to be flexible and dynamic and understand the unintended consequences of implementing technology that may have on other populations, and designing such a system which can sort of embrace and leverage the power of technology, but at the same time, continue to offer that and meet patients where they're at in person and provide solutions in sort of dynamic and different ways. And so some of the work that we've been focusing on is thinking about young same gender loving men, especially in stigmatized settings abroad in other countries, and leveraging sort of what was unprecedented or not feasible before was leveraging online social networks. So there's large, robust online social networks of gay men and same gender loving folks who can be tapped. But, one of the questions that remain is, well, we can now reach them in many different ways, but what do we do once we reach them? There aren't great models of how do we really engage people in health services or healthcare, once we reach them? What do we do? What kind of messages do we send? What kind of, how do people interact with technology? Sending a 5-minute video on a phone to people may not really work because, in today's sort of fast-paced social media landscape, people are getting used to these TikTok type 30-second, 1-minute videos or Snapchat messages where things, happen and disappear quickly. And so how do we design health information and outreach and education and empower and activate our patients, using these tools? I think there's a lot. So that's some of the types of things we're trying to learn and focus on is, thinking about the future and leveraging these tools in a way that people actually interact with technology and building upon that and leveraging sort of existing online social networks. And one of the things that we're learning in our work is some of the lessons, or many of the lessons learned from before, still stand. So, having trusted partners, having community organizations and community members lead the charge, and being able to empower them and support them to be the change agents that they already are, and giving them the tools and resources and getting out of their way. And so I think there's a lot of innovative models that are much more participatory and inclusive to empower communities to leverage tools or design new tools to actually address some of the gaps.
Really, really well said. I want to be mindful of kind of opening it up for questions from the wider audience. And you can go ahead and send in your question in the chat, or you can raise your hand and ask your question live. And really just want to take this moment to thank the panelists for your comments. We have more to go, so please continue to kind of share with us. And Victoria, I'll go up to your question, which is, you were acknowledging that Viraj is touching upon stigma, how stigma and medical mistrust relate to needed and proposed systems changes, some that are incremental, some that are radical. And I guess a question really for all of us to be thinking about is what non-healthcare system approaches might be promising to increase access. And I would say here, if I can add a subpart to that question, which I think is a really great step, is what lessons have we gotten from COVID that we can really use as we're thinking about that question, right? Because COVID has forced us to really evaluate the non-healthcare system approaches to reaching populations for testing and now for vaccination. And so this is a little bit similar to what we talked about earlier, but if anyone can kind of address that question, that would be great.
I was just gonna say, that it sort of frames it to me the same way that it relates to COVID, in that we are always seeking for that operationalization of social determinants of health in clinical settings, like a mouthful, right? But it's like, we need that information for us to make informed decisions, but we know that it's not on the medical provider really to solve those said social determinants of health. So I always think like that is what's missing, is figuring out like, who do we need to include and how do we include them to address those things? It's not just give you a referral for something. It can't be that easy, right? Like we need more concrete. And I think, I don't have the answer, but that's what I think about. If somebody has the answer.
Is it okay if I say something?
Absolutely.
I think that with HIV self-testing and testing, we have a good model of how communities and networks can be used to distribute what is essentially a technology. And so I'm wondering, what is being done, with PEP and PrEP? Obviously, if you can't even get it at a pharmacy, you can't have networks disseminate it, but, is that a fruitful path forward, whether it's for information or marketing? And then just to return to Dr. Safo's point, what do we think the promising lessons from COVID have been? I know we're all able to, enumerate the huge mistakes that have been made and gaps and groups of people who should have been prioritized immediately after healthcare providers and were not. And again, using these informal or employment-based networks, and by employment, I don't mean like institutional employment, but, small businesses, bodegas, the Bodega Owners Association, et cetera, for distribution of vaccinations. But I'm kind of struggling to think of what are the positive lessons learned there. So I'm interested in what other people think.
Yeah. The one that comes to mind, Victoria, and I'll answer it not wearing my moderator hat, but my provider hat, having done a lot of work around COVID messaging, is the incredible impact of trusted messengers and finding that it really, so thinking about vaccine outreach, finding that, sure, it helped that I'm a Black doctor and I showed up and I talked at, the PTA meeting, or I joined the church meeting, but it was really people's immediate friends and colleagues, people that they know, other home health aides or other nurses. We actually had a nurse who started off saying she wasn't going to get the vaccine. She's super loud and like in your face, and just like, I'm not getting it, no way. And when she decided to get the vaccine, the number of other nursing staff in our clinic that got the vaccine was so significant that I actually asked the Department of Health to invite her to future, talks, because she communicated in the way that really reached people. She could answer the questions and I think we've always known this with HIV. It's part of the reason why our HIV care delivery models involve other infected individuals that sometimes will provide care within the within the clinic. They'll talk to patients when patients come in, and I wonder if there's something similar within primary care that can happen. And I think it really speaks to Viraj's earlier point where he said, our system is broken and our system tends to be very reactive. If you think about what PrEP is a prophylaxis treatment, much more so than PEP. And so in a system that has patients that come in that have 7 medical problems that you're trying to get to and fit in your next overbooked patient, and the extra time to take to counsel, to think with a patient to get them on PrEP, I think can feel like it's not available. And so there seems to be here, thinking of the lessons from COVID, that particular space for how do we get trusted messengers in this, and how do we put them within these systems where they could potentially really reach people. And I think, David mentioned it earlier with those PrEP engagement, staff, and thinking about what the scale for that looks like, in addition to some of the other work that's done. But putting back on my moderator hat, I want to ask if other panelists, would really speak to that question, because I think, again, the knowledge from COVID has been painful, but, goes pretty deep.
I'll add in there, just putting, so I wear a lot of hats. I also chair the Brooklyn Ending the Epidemic, HIV Epidemic Steering Committee. I've been doing it for about 5 years now. And one of the places where we're at now is how has the HIV industry been significantly impacted by the COVID-19 pandemic? And then how did nonprofit organizations, programs, interventions, how did they stay alive and be proactive through this? Talk about innovation. A lot of administrative leadership had to really figure out in what ways, even if their doors were physically closed, how they could remain receptive to a very needy or population in need that exists out there. And you were kind of forced to figure out the resources that still existed out there that could get you the resources that you need to provide to your constituency. And so organizations, again, yes, they had to do the uptake in technology. They had to figure out how to go back to the door-to-door aspect, literally doing outreach, knocking on doors, and revisiting some stuff, and also tapping into financial resources that they could utilize to pay staff that were still able to go to work, but as well as help their participants get their rent paid, help their participants purchase their medications, get gas to drive to various appointments where they could still do that. And so folks became very, very innovative. And then again, this is particularly in Black and Brown communities where they didn't have that large cachet of funds that they could tap into to continue to provide services in some way, shape, and form. One of the things that I learned from attending several forums and having an ear to a lot of this stuff through the ETE work that I do is that some of the old stuff is really good too. Some of that old stuff that we used to do back in the day, back when I used to work in the South Bronx with Viraj and the Montefiore team, we used to go into the SRO hotels, knock down doors, provide prescriptions there, do doctor's visits, all of that, non-medical staff and medical staff together going into that stuff. Great old stuff that should be revisited in new ways in the modern day, is what I say we've learned from COVID, and great ways to innovate some new stuff.
Really well said. I think another question that comes up at this particular time, you can't really talk about COVID without talking about some of what we have seen around, anti-racism work that has had to kind of, be part of the conversation. And, just curious about some of the lessons that we have learned within medicine and public health. How do we leverage some of the energy around, anti-racism activism that is happening within the US, certainly in New York, around ending the HIV epidemic. And some of the panelists have spoken earlier to the realities that, when we talk about prevention strategies and uptake, it's particularly stark among certain minoritized populations. Any comments or thoughts from this group about using some of the lessons of this particular time to really push forward, efforts towards addressing the need to end the HIV pandemic through treatment and prevention efforts?
Yeah, Dr. Safo, that's what the Charge Project is all about. Challenging racism, HIV stigma, and homophobia and gain empowerment. That's what the Charge Project is about. We're looking very, as a kind of a part two, if you will, to the Change Project that looked at HIV stigma and homophobia specifically. We've decided to add racism in an apropos time to take a look at the way the systemic issue of racism has impacted the way Black and Brown individuals get access to care, particularly HIV prevention efforts. We found out in a lot of the group model building exercises that we've engaged in that Black MSM, SGL, and pre-identified individuals are still, no matter the age range, are significantly impacted by these perceptions and these perspectives they have about going into spaces and places where they have providers who do not look like them, do not come from their cultural experiences, and so therefore can't understand what's at the foundation of their prioritizations, right? And so therefore don't go, right? Or are resistant to going, or go and then don't go back, right? So these are some of the issues that we're coming across a lot. And with the aspect that, with the understanding that we're working with the SGL, MSM, POP, the intersectionality of being Black or Brown and being gay or identified, where, this is the aspect that we're strongly looking at. Why? Because we're trying to create the novel intervention components that will help put a spammer, if you will, in what that intersectionality looks like. We've got interventions that work on racism. We've got interventions that work on homophobia. But now what we're trying to do is create components that will manage the intersectionality of these, and hopefully will begin to positively impact some of those issues that are our particular population, our particular audience has to manage on a regular basis and has had to for decades.
Viraj, go ahead.
So I was just gonna, talk about how when we think about racism, oftentimes what comes to mind for a lot of people, and it didn't, it did for me as well, is like these individual level interactions that happen face to face. But, I think one thing we've learned, especially from COVID, that has really brought to the forefront is this concept and issue of structural racism, and how the structures and systems are racist and how they impede not only access to care, but they actually perpetuate poor health and mistreatment. So for example, with regards to PrEP, one of the issues is that places where people are able to seek PrEP, especially from lower income communities and communities of color, may not be equipped to provide sort of sex positive PrEP care for gay men or for transgender individuals, or because those in the places that do exist are able to provide sort of this optimal experience are don't accept Medicaid, don't accept uninsured folks, and don't have maybe don't have wait times, don't have have these sort of more ideal conditions. And so there's like this huge structural disparity or difference in how people can access care and where they can access care from, as well as the types of providers they can get care from, or there just may not even be there. For example, when I first came to Montefiore many years ago, there was not a systematic way of identifying providers who are either gay themselves or able to provide LGBT affirming care at Montefiore. You had to know someone or get referred to someone, but it wasn't sort of accessible. It wasn't out there. And so if you were a person searching for healthcare in the Bronx who wanted sort of LGBT affirming care and you weren't tapped into these networks, it would be really hard to do so. Hopefully, we're definitely not perfect, but we're building on this by trying to increase visibility, create provider lists, and create provider profiles where people can, see that such care does exist in the system and that we can provide care. A program that a colleague of mine, Dr. Jonathan Ross, is piloting currently with the Latino Commission on AIDS is actually expanding telemedicine prep to folks who may be uninsured or undocumented or just, not have otherwise great care, but using our current systems to provide care remotely to people who are dropping by at a drop-in center or from their homes, and which can overcome a lot with trusted providers and vetted providers. So it overcomes a lot of sort of structural and systematic issues. Again, these are sort of Band-Aid type solutions, but they seem to be working sort of for now and addressing sort of immediate needs while we continue to work on sort of longer standing issues.
Excellent. So any final remarks?
I would say, in my work at least, I think I work with community health centers across the country, as those are likely like the frontiers, right? Where hopefully those patients that will need access to PrEP and things like that will seek that. I always like to remind people, like, probably all of us here live in a bubble, know a community health center that is super competent, super easy, and easy to go. But the reality is, there are places over there that are still counting the homosexuals in their clinics, and and using weird language like that to sort of promote this type of service. So there's a lot of work to be done. I think that any little bit that we move forward, I think it will make a difference. I'm looking to see how we can speed up that process by hopefully using more technology. That's sort of the area that I am currently under. So
thank you so much. And Viraj?
So I just wanted to, be very brief and just wanted to say, there's a lot of us, speaking today, but we definitely do not have all the solutions, and we really need, your thoughts and ideas and working together to really come up with better solutions and better ways of doing things. So I think we can do better with our existing resources and existing tools that we have, but we need everyone's support in figuring out how to do those things.
That's perfect. That's like a nice segue to Alessandra, who's going to be telling us about the Designathon in a moment. But David.
Unmute, and hopefully with my move to the den, I will have less internet problems. So yeah, been working, Mr. Lawrence Francis, who's on this, who's attending this meeting wonderfully, a tried and true individual who's been pounding the pavement for years, continuing to educate and raise awareness for the community. Glad to have been able to work alongside this wonderful gentleman for such a long period of time. 20 years of doing direct service work in the nonprofit industry teaches a whole lot. And one of the areas where I know I'm personally still sore is that for all of the hard work, the effort, and the energy, and the millions of dollars that has gone towards this effort, we're still seeing these unfortunate trends. Yes, we are doing better incrementally, but we're still seeing these trends of particular groups, particular populations are still struggling with this particular aspect. This is by design, and I will be completely transparent about that. This is by design. And the isms that we talk about during this call, the isms that we hope to kind of thwart through all of these wonderful innovative approaches, those still kind of remain strong and are doing what they were designed to do. I think we need to look at stuff from that perspective. If we create interventions that help save lives by putting spammers in the work, we start seeing the wonderful benefits of the work that we've been doing for 40 years, right? Spending billions of dollars to do. So let us remember that that this is by design, and if that gets incorporated into that understanding gets incorporated into our innovation, we may see some wonderful.
Excellent. Thank you guys so much. I'm going to turn it back over to Alessandro to tell us about this magical designathon that I think we're also excited to have you contribute to.
Well, thank you so much, Stella, and thank you so much to the panel. Really appreciate you making the time for this. I think that it really sets the stage very well for the designathon and helps set the context for folks to really jump on as we to learn more about this problem before the designathon. So there'll be a lot of opportunity for folks to learn about this. Now, I'm just going to share my screen just to show our designathon here. And okay, we're up now. Swap displays. Okay, should be viewable now, correct? All right. So as you know, the designathon is going to be on September 18th. The application for the deadline, and I just noticed that there's a typo over there, is August 29th. So definitely please take a look out, keep a lookout for that specific date for applications for both innovators and contributors for innovators for the event. Now, just to give you a little bit of context about Firefly Innovations, what we are is a platform for entrepreneurs, for stakeholders such as researchers in public health, like some people here in the panel, and also for investors and partners out there that want to work in forwarding a lot of these innovations and entrepreneurial-based solutions out there. However, we focus on entrepreneurship that focuses on a nonprofit, for-profit, or even hybrid models out there. So what we're looking for is a way to really help be a vehicle for driving forward innovation that focuses on public health values specifically. And the way that we have focused on this through the Sustainable Development Goals, and one of them being SDG 3, good health and well-being, which is a really major focus of ours, but also SDG 10 in terms of reduced inequalities, and SDG 5, gender equality, which all have so much to do with exactly the challenge that we're focusing on. So if you look at the SDGs and the different types of challenges here listed, so much of it actually relates to this specific problem here. So what we look to do is actually take a cross SDG approach to many of the programs that we design going forward. And so it's really important to be able to reach these goals through entrepreneurship, through innovation, through new ideas out there. And we're looking to support communities that are really driven to develop these kinds of ideas. And
Alessandro, I don't know if it's easy to do, but right now your slides look like they're in non-presentation mode. So I don't know if you want to make them bigger so folks can see them. If it's going to take time, feel free to just leave it as is, but not sure if you're aware.
Is this better?
That's it. That's better.
All righty. Thank you so much. And so the three ways that we engage folks through our programs is through education and providing a background in entrepreneurship, but also in public health and how those two fields actually integrate with each other. Another is strategic science, which I will go into a little bit more deeply now, because this designathon is specifically focused on strategic science and how we are actually able to create more sustainable and scalable products and innovations, organizations, out of the research that is coming from institutions. So David has mentioned that billions of dollars are being funneled into this problem. Now, how is science and these institutions going to convert the great work that we do into actual products and ideas and organizations that could create more access for the communities that are disparately feeling this challenge, and for action, if you're looking at the Designathon and another program of ours called the Accelerator, really focuses on really driving forward ventures through mentorship, through networking, and through access to investments out there. So this is a way for us to really focus on the development of your own business model, your own pitches, and the way that you are going to structurally push yourself forward to actually reaching success in this field. And some of our programs that we have organized in the past is Solve-a-thon, a different type of design-a-thon that we did with MIT Solve. That also focuses on driving forward social impact organizations all throughout the world. So we are looking to connect to entrepreneurs internationally through Firefly. However, this particular program will be focused in the US. And we do focus on other types of topics such as healthy aging, which also very much crosses within the topic that we're focusing on now. And, you know, somebody mentioned earlier that, you know, this is certainly an aging issue as well. And so there are some past sessions that you can see on our website that relate to this topic that may provide some insight as to how this is a really growing opportunity here. And the Accelerator is actually a program that we're running right now over the summer, our second time, that includes 8 different ventures that are getting personalized education and access to mentors and consultants in order to drive forward their early stage startup and prepare for a demo day that will be on August 5th. Now, ventures that do enter this program at the Design-a-thon, and ones that would be most promising, certainly would enter into the Accelerator for our following program after this Design-a-thon. And for the Design-a-thon strategic science aspect of it, you know, our goals through this is really combining traditional public health and entrepreneurial methods to develop new communication strategies and tools, but it doesn't actually just focus on communications. There's so many different types of challenges and potential solutions that we've all mentioned to each other today in the panel. You know, many have focused on community organization, communications, message frames that could be more effective. However, it does certainly cross beyond that as well. And definitely fostering a multi-sectoral community of change agents. So folks who are interested in participating in this Design-a-thon with ideas or looking to actually support ideas that will be applying to the Design-a-thon, this is the place for you. So certainly look for details to apply for this. And so ultimately we are looking for novel solutions that will act as a basis for subsequent intervention research that we can continue. So we love to continue to work forward with these ventures that come through the Design-a-thon and also through our application process. So please, you know, consider how we will be working with you in an ongoing manner. And really what we're aiming to do is to generate and refine solutions, build engagement around really hard topics. It's not easy. Teach human-centered design and foster a really valuable network here. And this is not meant to take equity or IP or require any sort of, or have any sort of requirements in order to enter this type of Design-a-thon. Anybody is really eligible. And so if you have an idea or looking to latch onto an idea out there, this is the place for you. And some of the things that we will be doing throughout the day will focus on human-centered design and developing teams where innovators that apply to the program and contributors will be matched together to go through a day of introducing their product, meeting with their contributors that they have been matched with for that day to further refine their product throughout the day. And at the end of the day, ventures will provide pitches that will be eligible for prizes. And right now the amount is undisclosed, but this is a rising amount that we'll be disclosing soon about what the top 3 prizes would be, but they are cash prizes. And also you would be receiving support from Firefly Innovations going forward. And so once again, you know, the Design-a-thon process has innovators and contributors. We're looking to form up to 8 teams. There will be 1 innovator per team, 7 contributors per team. So there's 2 application processes, 1 for applications, 1 for innovators, 1 for contributors. 7 contributors will be accepted, and 1 innovator per team will be accepted. And we will be matching those teams together, and you will have a great day together in really engaging deeply into what your solution is, how to refine it, and to deeply network with folks that are also very much passionate about this topic and solutions out there, and have the skill set and the network to support you going forward. And a beyond being an innovator and a contributor, you could also engage as a volunteer, as a facilitator, to make sure that some of these design thinking exercises that we do throughout the day run as smoothly as possible, so that innovators and contributors out there could think as freely as possible throughout this really, really creative process. And just to recap today, there seem to be so many different types of potential solutions out there, and some that we do list on our website that you can check out at firefly-innovations.com/designathon. Include enhanced patient experience, strengthened community organization, fostering medical trust. Those are some major topics that we've touched on today. Relating to efficient data management, you can relate to what Pedro has been mentioning about sharing EHR records and making that more efficient and making that more shareable across institutions potentially. Thinking about product design, about how you're actually going to administer PrEP in a more accessible manner, or actually do it in a way that's going to deliver it to people in a more accessible manner in terms of actual card delivery that some people have mentioned during the panel, and also thinking about provider-based decision-making tools that could come through apps, which is some technology that we're seeing out there today. And some of the solutions out there is not necessarily based in medical engagement. It could be based solely in social marketing. It could be based in advocacy, with a goal focused on systems change. However, what we need to see is ventures that do focus on sustainability and scalability in order to make this a lasting solution. Again, thank you so much to our partners for making this happen. And again, the Designathon application deadline is on August 29th, and the Designathon date is on September 18th. Again, you can check out our website. Thank you, Stella, for posting that up there, and I'll bring it back to Stella.
Thanks, you guys. We apologize for being a couple of minutes over, but it felt really important to get you this information. You can check out the website for more. You can reach out to any of us as well. I want to start off by thanking our panelists, Viraj, Christian, David, and Pedro. I want to thank all of you for making the time to be here with us. Just your presence, I think, is really inspiring for us to see some of the minds that will be coming together to think about this important issue and to really design some innovative solutions to be able to address how to make sure that we're protecting our populations. And I want to particularly thank our partners, the CUNY Graduate School of Public Health and Health Policy, the NYU CUNY Prevention Research Center, the Einstein-Rockefeller CUNY Center for AIDS Research, and MOBI, which is mobilizing our Brothers Initiative. Again, thank you all, and we're going to go ahead and end tonight. Hoping to see you guys soon. Bye, everyone.
Bye-bye.
Take care.
Bye.
Thank you.